everyone. I regret that I cannot be with you in person today, and I appreciate that the organizers with this Harvard PEPFAR meeting have allowed me to come in via video. I've been given a few questions to answer during this session, so I'll just go right to them. But I do want to say that I think it's a remarkable opportunity to acknowledge all of the individuals, countries, the talent in countries, our colleagues in ministries of health, and all of those in community-based organizations as well as multilateral NGOs that have played an orchestrated effort to bring the resources and talent content to bear in all of the programs that have allowed for people to move into delivery systems that have effectively treated their HIV. So we're now approaching a 17 million number, exceeding that actually, and that is just a remarkable achievement. All of you attending this meeting, listening to this meeting, and all of our colleagues in country are grateful for the opportunity that has come to us with this effort. The first question is, what challenges did you face when you became Global AIDS Coordinator? Well, first I want to thank Mark Dybul for his leadership and Tony Fauci for both of them in the early years and thinking of setting up PEPFAR, the time and concern that was given to understanding the populations that we were going to be responding to and defining the countries and then the systems that would be invigorated to stand up delivery systems that really were not in place. A remarkable achievement. I would say that Mark and his staff left a approach that emphasized the emergency response aspects of it and quickly tried to put program on ground. But Mark had to, the PEPFAR effort in the initial years had to define locations, sites, as well as find those who in country and outside country would have the ability to turn it around into a delivery system that effectively would be there for the duration and would be part of what patients and patients' families could access in the way of enabling services that identified and retained people in care over time. All of that initial groundwork of site understanding, population, understanding access points, retention strategies, getting the procurement distribution systems for both pharmaceutical and laboratory stood up, each different in not only the capital cities, but also those cities that were distant, required a huge learning curve for both our partners in country, but also for the US government's orchestration of this response. So all of that had been engaged and started in the initial countries. And I came in really with much of those decisions having been made and really was in a position where we were looking at the likelihood that these programs were integrated into the delivery systems of the country and would be continued by the country once PEPFAR began its wind down. So I really emphasized the country ownership aspects of it and tried to unpack exactly what country ownership meant. And also, I would say we pivoted toward increasing more of the PMTCT responses and focused in a more aggressive way on the HIV and TB connection, and really tried to, in the countries we were already in, take over the TB strengthening response that was also part of USAID's agenda in their TB offices. So I would also say that when I was the coordinator, we announced that the 1 millionth baby was born HIV-free. In 2018, we now had 2.4 million babies were born HIV-free. And I think that is a remarkable number. Over 17 million now have been identified, tested, started on antiretroviral therapy, and have been continued on it. Our ability to assess how well they're doing with viral loads is rapidly expanding. And I know Debbie will go through those data for you. But I think that that was the main response and initial prioritization that we put forward. I would say finally that we also saw a need to take some of the decisions around the prevention part of the continuum and identify those that were high impact prevention interventions, and to emphasize in the country operating plan prioritization of funding that the high impact prevention interventions would be funded first. And when those were funded, you then could argue with your country operating plan budget to go into other areas. But we eliminated a lot of the early funding decisions that were not based in an evidence base. And as we continued to collect data, we refined that to demonstrate the decisions for high impact prevention interventions were the correct decisions, and that our ability to decrease the number of new seroconversions was enhanced. The second question was what challenges remained when I left PEPFAR? And I wish that I could say that I took care of all of the challenges successfully, but I know that that was far from the truth. We hopefully left our program in a state where our Ambassador Birx could pick it up, continue to identify areas that were mismatched with our investment not being aligned with numbers of either new patients being identified or those in care to be continued in care, with outcomes such as viral load, et cetera, being the type of outcomes that we were aggressively trying to achieve. And I hope that our ability to allow for that pivot with Debbie's focus on populations that were highest risk, largest numbers, and making those decisions to continue to concentrate PEPFAR efforts in those high volume sites, and to pull out in a gradual way from those sites that were less productive. I would say that the issue of country ownership continues to be the main challenge that's in front of us, and our understanding of how the NCD progression as our same HIV positive patients are now getting older and presenting with high blood pressure, diabetes, coronary artery disease, malignancies, upper respiratory GI infections that need to be diagnosed and treated, some in a chronic progressive manner. So a delivery system that has medical records, has laboratory and procurement distribution support, can more easily expand into the added service needs that the NCDs present. And I think the PEPFAR platform really is one of the stronger platforms on which that kind of expansion can occur as NCD and universal health coverage becomes a firmly committed to target. So our third question is how important a role does academia play in defeating AIDS? I think academia plays a critical role, and I think we in the academic community in relationships with PEPFAR programming from its inception have demonstrated a partnering that needs to continue between the academic institutions in country with ministries of health and civil society. Those three stakeholders remain the critical ingredients to a successful self-correcting program. And when the allocation and decision making moves to local decision makers, that ability to refine and target your program decisions, outcomes in terms of populations targeted and outcomes delivered becomes a self-correcting, locally driven process. And I think the challenge of local ownership of these programs continues to be paramount, and I believe will, as we move into NCD UHC delivery systems, will continue to be our biggest challenge. The need for that academic, Ministry of Health, civil society triumvirate is, I believe, the secret to a continually responsive set of patient-centered services that will embrace our populations in care and services as they move forward. I think the PEPFAR platform has created a strong enough platform to add these services to. I believe academia needs to continue to document outcome impact, but just as importantly, needs to look at counterfactuals in describing scenarios that would ensue if we were not standing up these programs. I think that donor support is often best justified by these types of outcome studies that again argue for continued impact and continued shared responsibility in a sustained donor presence, an expanded domestic investment with civil society, those who use and depend on the services becoming active in planning and allocation decisions. So I would say that I believe was the last question, and I really want to say how much I regret not being able to celebrate with you the achievements of the PEPFAR programming, the unique role that Harvard has played in much of this should be acknowledged, and I want to formally acknowledge that, and say that it is an exciting time for us to think about not only the distance we've traveled, but also looking ahead at the distances that are in front of us, the need for a continued collegial convening of both brain trust and implementation power remains the case. And as the world turns to a UHC target, I believe that triumvirate of academia with donor support and domestic civil society convenings is the secret to a continued relevance so we can move toward healthcare for the planet. So thank you very much.
Good afternoon, everyone. It's such a pleasure to be with you, and so great to follow Ambassador Gooseby, who it's really hard not to have him here to answer questions because he was such a great leader during that era. I want to just, before I kick off, just acknowledge a couple things. One, hearing Maureen talk about the early days of the response in Malawi, I couldn't help but notice one of the slides was from 1999, which is when I was there as a medical student. Working with Tony Harries and others in the hospital and the TB wards, and that's really, I think, why I'm here today, because that lit the spark in me to try and reverse some of the devastation that we saw there, and really a generation being lost. So thanks, Maureen. This is really coming full circle for me. Followed by hearing Ken asking a question and thinking back to the mentorship that I had here at Harvard from Ken and Rochelle and Bruce and so many others. In Ken's case, kind of teaching me the principles of cost effectiveness analysis and how you use models to make better allocation decisions. And those lessons were very well utilized, as you'll see during my time at PEPFAR. And I also want to acknowledge the fact that Ken actually, I don't know if you remember, sent me over to the Center for International Development at the time, where Jeff Sachs was kicking off support for this thing called the Global Fund. And next thing I knew, I was off in Malawi helping them to support writing the round one of the Global Fund. So yet again, it's a wonderful circle, and things are getting better. So lastly, I just want to acknowledge the amazing people that have run this program, and being able to, Mark for hiring me, but then being able to work with Eric Gooseby and being able to work with Debbie Burks, who provided brilliant strategy from Atlanta as CDC director there for HIV. It just has been a tremendous opportunity to learn and try and improve these programs. So I'll dig right in and talk a little bit, give you a little bit more background about the reauthorizing legislation and the economic environment at that time. Talk a little bit about then how we reacted and consolidated some of the gains and tried to become more efficient given that economic environment. And I'll talk a little bit about country ownership, but I think Ambassador Gooseby covered that well. And then I'll move into how we began to, in that context of country ownership, accelerate our efforts to scale up and make our programs more effective through a variety of means. So first off, as others have said better than me, none of this would be possible without the support of Congress or multiple presidents. And this is the Lantos-Hyde bill from 2008, and it was a very hard-won reauthorization that is credited to many people, and reauthorized the program for $48 billion over the subsequent 5-year period. Most of the provisions in the original authorization were maintained in this authorization, but it was intended to really move more towards a sustainable response. But I really would argue it was also meant to keep some of the elements of the urgency and the emergency response that helped make PEPFAR successful. And there were two additional elements, one around a focus on preventing mother-to-child transmission, which I'll come back to again, as well as a provision around forming stronger partnerships with host country governments, and I'll come back to that in a little bit as well. So it's worth noting that this legislation amazingly took place at a time that many people say was the largest economic decline in the U.S. since the Great Depression. So this was going into 2008, 2009, and as you know, we had actually a prolonged recession in this country, which I think makes this all the more amazing that we're standing here today talking about the successful program. Yet despite those economic conditions, the legislation passed through both chambers, as you can see here, on July 24th, 2008, with broad, but as you can see here, by those vacant spots amongst the red side there, it was not unanimous support. And I think that really brings us back to something Mark was talking about, which is, we really do need to think strategically as we're trying to tell the story of our programs and their importance and tell them to the right people at the right time. Because broad bipartisan support can't be taken for granted. So just taking you way back on this journey back to what things felt like or looked like in 2008-9. We had almost a doubling over the first several years. Then we moved into this sustained period of adding almost 700,000 people on treatment every year, between 7, 8, and 9, which was just amazing. But we were also acutely aware at that time that we had a very, very long way to go. There were over 30 million people living with HIV in the world, and based on eligibility criteria back then, they weren't all eligible for treatment. But of course, now we know that we're going to need treatment eventually. So we were acutely aware of that long road that we had to hoe, and that it was unlikely that we were going to be able to see the year-over-year increases in budget that we saw in the first 5 years of the program. as much as we might have wanted them. And so as I talked about, so in that setting where we had so far to go, yet we were very likely to see budgets decline or flatten out, I actually came back here and spoke at Mass General Infectious Disease Conference in June of 2010. And it was a very challenging time within the program, I think, because of that match between our broad recession and a need that was so great. And so what we were doing, what I talked about during that conference were actions that we were taking at that point to try to become more efficient, try and increase quality as a means of driving better outcomes throughout the program and allocating more efficiently. So it was really the second phase. I think of it really as consolidation of gains, trying to improve quality, and really looking for ways to drive efficiency. Not efficiency as bare bones, let's get to the bottom, but really efficiency in the best possible way, blending effectiveness as well as cost to make sure that we're getting the outcomes for the best value for money. And as we wrote about in this article a couple of years later about these efforts, there were really kind of three main components of it. One was around innovative and efficient implementation, and that had to do with improving the technical efficiency of programs, everything from small investments to try and improve retention as a means of improving overall virologic suppression, as a means of getting better value for money for the programs that we were supporting. Allocating resources for greatest impact using a lot of modeling, as well as, we couldn't say innovative financing in the US government, but we could say creative mechanisms for healthcare finance. And that was a means of thinking about using incentives, leveraging health insurance and other means to make the program more sustainable. There was also a big push on economic and financial information, as well as national collaboration and alignment, and I think Eric spoke well to, in particular to that last one. But I'll focus here on what we did around economic and financial information, and we put a lot of time and effort into trying to generate better information, and really a lot of this started from a group of economists that Ambassador Birx had working down in Atlanta and was kind enough to. They were frequently seen on the shuttle up to Washington, and in fact, eventually she seconded a couple of people up to us and helped to really change the game in the way that we were able to use information within the program. And so let me tell you a little bit more about that. And so first, this was a big program, and it scaled very quickly. It was at this point, was a couple of $1 billion a year, and the question, several $1 billion a year, and the question was, we knew quarterly outlays to partners, but partners were often conducting a full range, myriad services, everything from counseling and testing to doing a little prevention over here, to doing some treatment, to maybe supporting some health systems infrastructure development over here. So we had generally a handle on our outlays, but we couldn't actually articulate very well the actual cost per unit of output. What were we actually getting in terms of individual program outputs for the dollars that we were putting in? And as you can imagine, putting together a system to track that sounded easy on paper, but to actually operationalize it was very challenging because partners were doing so many things. It was such a vast program. But through a series of pilots, we made traction and began to see the value of the program. And I just wanted to point out this, some early data from our pilot in Mozambique, where we looked at across each of the partners that was implementing programs, and this is the case of the cost per unit of HIV testing and counseling delivered by partner and by province. So if a partner was working in multiple provinces, they reported their cost per province. And so what that did is it gave us an extraordinary range, as you can see, from a partner that reported about 1 cent per delivering this service to almost $700. Now, absolutely, there were data challenges and all the things that you have in big surveys like this. But what it did is it began to give us a much stronger foundation for having dialogues with partners, because it may not be wrong that one partner was taking $64 and another was taking $8, because that one that's $64 maybe delivering in very harsh circumstances, lots of transport costs, lots of personnel costs, and so we were able then to work with partners to begin to bring in some outliers and have a better conversation. Not cut out costs for the sake of cutting out costs, but really to drive better programs. Some of those delivering for 1 cent should not be in the business of delivering HIV testing and counseling. In fact, that's probably poor quality care. So it allowed us to have those conversations as well. So those efforts around collecting better information, we're not the only effort in this regard, and I want to just highlight a couple of things more on the technical efficiency front. The pool procurement that really started in the first phase of PEPFAR, but we expanded it. The expanded use of generic antiretroviral drugs, we're up to 98% of all ARV packs as generic in 2011, and we enjoyed every year calculating the cost savings to program that then we were able to funnel back to the program and hopefully save more lives. We also did things like switching from air to land and sea freight, which took better planning, better projections, but if you could get that right, then you could actually save a huge amount on your FedEx bill. And then, working to maximize our investment for trying to better coordinate across with the Global Fund and trying to eliminate parallel systems. And I'd be the first to admit that was a process and not something that we did overnight, and it's continued with Ambassador Birx's great leadership. So all this was important because, in fact, funding did level off. And the funding situation really hasn't changed since. And so I think what we tried to do at that time hopefully began to lay a better foundation for an environment that may look like this for some time. So I want to shift. So one of the things that we've talked about a lot is, if we are getting value for money, that's obviously important from a life-saving standpoint, but it's also important as we think about handing over these programs. We may have tried to build the Cadillac at the beginning. You don't necessarily want the Cadillac to be the car that's driven for the long run. I mean, you want everyone to get the best health care. But in terms of the program, as you hand it over, you want an efficient program that's delivering the best outcomes. And so all of the work we did really informed the conversations that we had in our country ownership dialogue. Because much of this was really beginning a dialogue about trying to create better sustainability and beginning to look at countries as partners and less as recipients. And in fact, we've heard today how much leadership has developed around this issue in countries, and I think it's just magnificent. So one of the things that we used was the partnership frameworks, and as I mentioned earlier, that idea developed out of the legislation, and I think was a fine start to having much more robust dialogues with countries about what their intentions were, about what the U.S. could do, and with civil society and people affected by HIV, who could really commit in a different way and with a different mindset to a long road ahead that would have a change dynamic. So we signed 22 of these, and as you can see here, they often had very high-level commitments on the part of the U.S. government, as evidenced by Secretary Clinton signing this in Hanoi in 2010. Many heads of state were involved in the countries, and it led to great discussions and very practical brass tacks discussions about the commitments that countries wanted to make. These were not forced discussions in many cases. Countries wanted to lead these, and there's a reason why, as you can see here in South Africa's partnership framework, there were many domains in that left column, but the first sort of expected contributions was the South African government, followed by the US government, and followed by civil society, faith sector, and other organizations there. So I think there are things we might have changed had we had the opportunity to do it again. These were not 100% successful, but I think one thing we can probably all agree on is that they were successful in starting a very important dialogue that is continuing to this day. So I'll finish with three rather quick examples of things that we did in a fairly focused way to try to increase, not only further increase scale up, but increase the effectiveness and impact of the programs. One was the global plan for the elimination of PMTCT and keeping mothers alive. There was an echo of that in the legislation. Trying to accelerate the amount of science we had going on in the program, as well as data to policy, and our continued combination prevention and ART scale up. So first about the PMTCT initiative. This really grew out of a crisis. In 2009, there were 370,000 infants infected with HIV in the world. And there were about 50,000 women who died while pregnant living with HIV in the world, which is an extraordinary number, an extraordinary tragedy. And I think that we had a feeling as we discussed how to move forward, and we allocated additional resources, and we made a number of actions within our program, but we realized, in speaking with many others, the world needed to do something differently. The world needed to come together. This couldn't be just a PEPFAR effort. And so in that spirit, we brought together a large coalition of people through this plan called the Global Plan. That's a long name. The Global Plan towards the elimination of new HIV infections among children and keeping mothers alive. And the keeping mothers alive component was very, very important, because as much as we appreciated the wonderful studies around single-dose nevirapine, they were targeted towards the prevention of mother-to-child transmission. And we were really trying to move away from that and towards a world in which we were spending as much time and effort keeping mothers alive as preventing transmission. So Eric Gooseby came together with Michelle Sidibe at the time, and they chaired a task team that brought together many of the member states, including those most highly burdened countries, as well as international organizations such as the Gates Foundation and the Global Fund, of course, Islamic Development Bank, civil society, and the private sector in a very big way, in fact. Becton Dickinson, a number of the pharmaceuticals, Mac Foundation and others made quite substantial contributions as we went through this process, which was really great to see. And it began to feel like more of a community working on this as opposed to just PEPFAR driving this single initiative. Of course, the AU is very active, as well as quite a number of UN organizations. There was actually a family planning component to it, and UNFPA contributed a lot. I have limited time, so I won't go into great detail, but suffice it to say that from through 2013 or so, we saw some very dramatic declines in a number of the countries, as you can see here. And those where there were fewer declines often had challenging situations, and we needed to go back and collect more data and collect our thoughts and do things better. And Ambassador Birx may talk about some of the efforts that were made after that to try and really take this to the next level. But what was exciting was that it really did lead to some groundbreaking progress, and I don't say that lightly. So for the first time since the mid-90s, we got to under 200,000 children infected with HIV annually, which is still far, far too large a number, but it was a heartening change, and it was good to see that the community could come together and drive this change together, which is a 43% decrease in the number of new infections in children during that period of time. At that point, we had gone through the WHO guidelines change, and it was all about full treatment for women at that point, and pregnant women. 7 out of 10 pregnant women in our programs had received full ART for prevention of mother-to-child transmission, and about 6 of 10 mothers or infants were receiving coverage during the breastfeeding period, which we know to be extraordinarily important. So I'll shift gears quickly again and just talk about how we were able to bring science more to the forefront in the PEPFAR program during this era. And in the first phase of PEPFAR, we were so concerned about scale up, and we didn't spend a whole lot of time to stop and think about the kinds of science that needed to be done to drive better programs. But in this phase, we did take the initiative to do that. And I helped Ambassador Gooseby start the Office of Research and Science at the Office of the Global AIDS Coordinator. And we collaborated with NIH and CDC and USAID on a whole series of RFAs that I think led to science that was very targeted. We targeted it towards where we had the greatest investments, where we saw the biggest gaps, where there were new diagnostics or new therapeutics that we didn't know how to deliver very well, and we tried to get those answers quickly as we could and fed back into program, and that was a very important process for us. We also established the PEPFAR Scientific Advisory Board that brought a lot of great people together and ultimately helped us better ground our programs in and policies in the best science. And I'd just like to say that those bodies that I just talked about became particularly important in 2011, for instance, when we had the HPTN-052 study results come out demonstrating that there was a prevention, a heretofore not fully recognized but suspected role of treatment as prevention. So with a 96% decline in transmission within serodiscordant couples, which very quickly catapulted treatment up on the table to sort of leading the prevention, the biomedical prevention interventions. So from that time on, through discussions with the Scientific Advisory Board, and I still remember the day when Tony came down and sat down with us to basically talk at length about the implications of this study for our program, and it was a very exciting time. And ultimately, that helped us to bring together the concept of combination prevention, which was treatment, it was VMMC, it was condom use, and ultimately PrEP and other interventions, as well as the socio-behavioral kinds of interventions that we've been talking about earlier. And all of that, together with quite a bit of mathematical modeling to demonstrate that we could chart a new path forward, led to an announcement on World AIDS Day in 2011 by President Obama, who committed to really kind of stepping up in the treatment realm. We knew budgets were relatively flat. We had a massive recession that we were just coming out of, but he committed to an unprecedented 2 million person scale up over the next 2 years from 2011 to 2013, as well as a whole host of combination prevention interventions such as VMMC, greater attention to condom use, and he made some great pledges on the domestic side as well during that speech. And I'm proud to say that we ultimately hit those targets within the PEPFAR program, we went well over 6 million by that target, but we also moved forward quickly with VMMC as well as our PMTCT initiatives. And I think we've taken so much away from this, and I just want to restate a couple of things very quickly. I think I'm at or over time, well over time. It really was, it was a pivotal era. I mean, you live through these eras and it felt very pivotal because we were trying to scale up, but we were also trying to do better in terms of putting countries first and putting them in a position where we knew they could rightly lead these responses. And I think that dialogue really did change things. That's really a credit to Ambassador Goosby's leadership during that period of time. And you might think that would have slowed us down, but it didn't. I think it accelerated everything we did because those dialogues made people more motivated to scale up and to work with everything they had and mobilize resources more on the domestic side where possible. I think we really were able to build systems both internally as well as externally. You think about our expenditure analysis system that we built. That's been picked up and adapted by other donors and is probably a best practice as we think about applications to global health more broadly. And I'm really proud of the science that we were able to generate and use during that period of time and worked so closely with NIH and each of the agencies on that. So I hope I've convinced you that I think this era that I was asked to speak about really did bring interventions to millions of people in an increasingly new way and hopefully can serve as a model for other efforts. And I just want to say, how proud this program makes me to be an American, but I'm also so proud of the country governments that we've worked with and the people living with HIV who have led this response, and I think it's a very bright future indeed. So thank you.